know her more because the work she does is pretty impressive. We thought that we would, because she has a really good view of the profession of midwifery from where she looks in at it, with different points of view. We thought that she could give us kind of an update on where midwifery is standing right now. 2020 was the year of the nurse and the midwife, according to the World Health Organization. And wow, was it ever. So we had people clamoring for midwives and hoping to find a way to deliver their babies outside of the hospital in March and April. And all of a sudden, people were talking about midwives. General lay people were talking about midwives more than I've ever seen it happen. You know, just as part of just general conversation. So we definitely had a year of more interest. And I think in our orientations every week, we've pretty much like tripled the number of people inquiring every week about what we do. And I do find that to be a great opportunity to just talk about midwifery and talk about what people's expectations for their care should be, what they should be looking for, whether or not they ever actually come to us at all. I think it's a great chance. So I think that one of the things that we saw was with the pandemic, and I'll let Ginger talk soon, but was that we actually really did increase the number of out-of-hospital births we did. In 2019, of our births, we had 31% of our births were out of hospital, and in 2020, 46% of our births. So almost half of our births were outside of a hospital. And I thought that was really telling and really great because I'm a big fan of out-of-hospital births. So I have to say that it made the year feel a lot more normal to me to not be in the hospital with all the, just the fear of this pandemic, which is a real fear, but it was easier to deal with on a one-to-one level with people rather than a whole institution full of people who were all trying to figure out if they were safe or not and how to keep patients safe and their babies safe and everything. So it was nice to be outside of a hospital. So anyway, so I think the reason why they ended up, and I think if you would agree, the reason why people ended up choosing out of hospital birth, main reason was the fear of not having their partner with them. And that was a fair number of places in New Jersey excluded partners from coming with them into the hospital to give birth. And I think that was terrifying. They also were afraid that they were also unhappy they couldn't have a doula. We didn't have doulas in Morristown Hospital for several months, and we could not do water birth for quite a while. And all those things kind of led to more interest in out of hospital birth. So I have to say, though, I do believe that we're seeing people trend back into the hospital again. So we'll see what happens. I just think if you would talk a little bit about what it means to be the year of the nurse and the midwife and what has happened with that over this year. And I think you said it extended into this year, right?
Right, Lisa.
Mm-hmm.
Sure. The World Health Organization every year creates sort of this high profile of a professional or a concept or a health issue that is then sort of led to be a guide with toolkits and social marketing materials to feature whatever that topic might be. And in 2019, and there had been a lot of lobbying for this by the International Confederation of Nurses and the International Confederation of Midwives to lift up the combined two largest health professionals in the world to receive that designation. And it was granted in 2019, long before anyone forecasted the COVID pandemic. And so instead of, having the highlight be on these two professions and the contributions, not only from decades of science about the positive outcomes of the role of nurses and midwives, but to get governmental agencies to lift up and enact new policies related to practicing to the full scope of your licensure and education, wherever that might be in the world. COVID took the front stage. And what actually happened was the bravery of the nurses and midwives faced in giving and delivering care during, a pandemic that took us to a global catastrophic sort of place in our history, sort of set aside what was supposed to be impacting, elevating these two professions with specific causes. So the European World Health Organization, kind of in the fall of last year, said they were going to extend it. The WHO, World Health Organization, has extended it, not quite so vociferously as the European WHO, but several American organizations have also attached on to that extension for 2021. And the hope being that we can sort of recalibrate what the intention of that was, to speak about the positive contributions and not let COVID be the only conversation during that time.
Right. Well, I think that we had spoken and talked about the fact that there is a lot, in response to this, there was a lot of talk in DC about midwives in particular. I mean, they're great too, but I'm just about midwives, and there's a lot of inflation right now that is really going to impact us in a good way. And so even if sometimes I feel as if we are not, sometimes I feel like nobody knows about us and what we're doing and the good that we do, I think they actually do. And that's one of the reasons why it's nice to talk to you, because I live so much in a little bubble, like in my little world, that, I just left the hospital this morning after being there for 24 hours. And so I hardly have time to look up to see what else is going on. I would guess that lots of people who will listen to this are the same. And so it's nice to hear from you what is happening in this country to benefit midwives, and what's the hope we have of growth and acknowledgement or recognition, I guess.
Sure. I think, Lisa, if you could, I always look for the value in challenges. I'm an eternal optimist for those people who know me. And I think there's always a place of improvement in difficult space. And we could not have had two more catastrophic events happen. And we're just going to talk about domestic, the US right now. We could do a whole nother hour on international health. And I know you've got some international folks on here. Is the convergence of maternal mortality, which since I'm going to say 2017 became more of a general layperson's awareness, even though we have the data from the last 20 plus years now that maternal mortality was rising, it really hit center stage, particularly about Black and Brown families and Indigenous populations in the US converging on top of COVID. And what we've seen happen, and you eloquently sort of laid it out, I agree with you, Lisa, 100%. What was driving people out of the hospital when COVID hit was fear. And I don't think it was just fear of their partner not being with them, but fear of transmitting, acquiring a disease in a very vague uncertainty of how transmission happened, and that it just wasn't a healthy place to go have a baby if you're a healthy person. So we'll keep that in the context correctly. So in preparation for this talk, I try to stay on literature, about every week. It's interesting what I found, because as you talk about, your head is should be focused clinically. And what's happening in the world around us as of 2021 is a variety of publications talking about this conversation. And whenever anybody talks about midwifery who's not a midwife, my ears really go up. Like, what are they saying about us? And so a very powerful document came out by AMCHIP, which is the Association of Maternal and Child Health professionals. This is a very diverse organization. It's been around a very long time. And they released an article in the last month, and this is the title of it: Increased Awareness of Midwifery and Home Birth Options in Response to the COVID Pandemic. And what they have to say in their conclusion is remarkable. And this is the kind of conversation I think that people need to hear in the context of change. This isn't just midwives advocating for change. This includes physicians from a variety of disciplines that intersect, as well as consumers. And their concluding points is that we should ensure the community is made aware of and educated on all options available to them. We should encourage and ensure that all healthcare providers provide respectful care and advocate for policies that support all birthing options for families. Why this isn't in the New Jersey governor's office and every other governor's office in our nation, I don't know. But that's sort of a lens on a health provider organization. The other, I just printed off this morning. It's free for anyone to go online and print off. It's probably the most accurate discussion of midwifery policy in the US I've read to date. And I've been co-authoring with a couple other colleagues of mine an article, and it hasn't got accepted for publication yet. The COVID-19 pandemic, this just came out 2 weeks ago. A focusing event, that's a public health term. It's not something they made up, to promote community midwifery policies in the United States. And this article is full of the challenges that we're having in our country about how midwifery is practiced, where it's practiced, the challenging conversations of 50 state regulatory bodies, and how complex it is to talk about midwifery today in America. I know you and I've talked about that, Lisa, and I'll pause here for a moment before we hit the national legislative scene, because state legislative issues are key to change for families. And if families don't understand, we need them more than anybody else to understand.
Right. Well, that's the only way anything changes is if they want it. I try to tell clients all the time that I want it. I mean, I want it for them. I want all of this change for them, but I can't change it. Like, that has to be way bigger than me to make change. And access to birth choice, as we want women to have choices in everything. The choice of where they give birth, I think, is a very reasonable thing. I mean, in New Jersey, we are kind of we are licensed, and we have regulations that allow us to deliver babies outside of the hospital. They're very clear and they're great. I mean, I think we have a good license in New Jersey. I think we can really practice very fully as midwives. But the one part of it is that we have to have a physician consultant. And that part of it is difficult because, I mean, ACOG doesn't believe in home birth. They have changed their position multiple times, and their most recent position, as far as I know, says, we don't think home birth is a good choice, but women should be allowed the choice. Women should have the choice. And so they've stepped a little bit closer, and it's gotten a little bit better. Of course, they are good about birth centers, and we also work in a birth center, so that's nice. But I think that it's very difficult to grow out of hospital birth when we're directly tied to another profession who doesn't think we should do it, so it's been tough, but it still exists. And thankfully there are some physicians in the state who are still supportive and helpful to us, and we thank God for them, for sure.
Well, the point of this article in particular, it being a focusing event, and what are the key metrics, now we're talking data that can help drive change, that legislators, or quite frankly, their legislative aides understand, that then influence their legislator how to vote. This is really the level of understanding our consumers have to be prepared for. telling our story is one thing, and each of us have a story. I've had 4 births, 2 in a birth center that I helped start, 1 at home and 1 in a hospital. In the midwifery service I started, I was in and out of the hospital in less than 3 hours. I don't think it depend. I don't think the issue is where you give birth. It's how you're respected, and it's what you're wanting to have with seamless, safe care that every other high income country in the world where midwives do nearly the majority, if not the majority of births have integrated seamless care. We're not willing to do that in this country because of various obstacles. And so the story has to be, not only your personal story, but why is it that, you know, other countries can have these safe, integrated levels of care, but we're unwilling to do that in the United States. Yet we face the highest maternal mortality, and 98% of births, by the way, are in the hospital. Help me understand that dichotomy. And they can't, because there's no evidence to support it. It's just, it's power. And as we know, all the other issues. So, I think without a strong, educated consumer voice to assist the midwives and the doulas and the birth center owners, state by state by state, we're not likely to see change happen very quickly. But the window of opportunity is right now, because it's a focused event. It's maternal mortality and COVID combined. And we see that on 3 federal bills coming into the pipeline this year.
That's great. I'm really thrilled. And I think that everyone, you have to take advantage of these moments. And I hope
Yes,
that
you do.
I really hope we do, because it's incredibly important. I mean, New Jersey has the 4th highest cesarean rate and the 5th highest maternal mortality rate. And that's insane to be in New Jersey and have that happening. And we midwives and doulas and nurses and and physicians, everybody's interested in making change. But I've said many times to many people, the reason why midwives have such good outcomes has nothing to do with how much our education is or how smart we are or that we have learned a special secret medical way of doing things. It's really, we just do nothing and we just allow people to have babies. And midwives, I feel like my job is to create a place where a woman can give birth, no matter where that is. So in the hospital, in their home, in the birth center, to create the feeling of safety for them, and they feel safe, private, unobserved, the things that they need to feel. That's my job, to create those things, but not to actually give birth for her or really help her give birth, but watch her give birth. And then I'm there, in case I'm needed. And that, we know, and the studies, the data all shows that the evidence shows that that's the right way to manage a physiologic event like childbirth. And that gives you the best outcomes. And yet, people still don't know what midwives are. They don't know what's different about midwives from obstetricians. They don't know the different types of midwives. And really, overall, we're not listened to, like what we do every day, which is good. And it has great outcomes. We have a very difficult time getting a place at the table many times to even talk about, how could hospital policy change? How could we do something different that would help women, survive childbirth? And so, I get very discouraged. And
I'm going to try to change that for you, Lisa, and for your listeners, because look, I've been in only maternal child health now 4 decades. I was a scrub tech with women's arms and legs restrained with leather. The baby delivered. I'm wiping the brow of the obstetrician, handing them instruments, put the baby in the isolette. They circumcise the baby boy. Then they come back and deliver the placenta. Then the mom recovers in the hallway with a curtain draped around her for 2 hours. And then she's taken to postpartum. And then father of baby partner can see the mother and the baby. So look, we've come a long ways, even before my time in birth. And I think some things have improved and some things have perhaps cause more birth trauma, to be quite frank about it. But in my 40 years, for me, I have never seen a more prominent time that midwifery, maternity care, childbirth has been talked about in the United States. It's talked about all the time in other countries. Just look at the NICE guidelines in the UK. Are they perfect? Probably not, but they're revised with a team, and the whole country knows how you're going to get maternity care. And there's no games afoot there. But here we have a different political sort of environment where for major policy change, it has to go through a legislative discussion. And of course, the lobbyists become the influencers. Probably the biggest lobby against us, and I'm going to say us for those who believe in what we're advocating for, choice, midwives, doulas, birth centers, home birth, is the AMA. The AMA, the American Medical Association, does not represent all physicians in this country, but they sort of stand out as the big lobbying agency that holds this big stick over everybody. I describe them as Goliath because I think they appear that way. Certainly in my testimony last week for Kansas, spewing things that are simply inaccurate, but they have the authority and sort of this power dynamic that still lets their voice carry the last word. But now we're seeing growing legislation with congressional people like Cory Booker and Vice President Kamala Harris and all kinds of people, both in the Maternal Health Caucus and in the Black Maternity Care Caucus, which is combined a very large group of congressional representatives trying to learn what is a midwife, what's the difference between a midwife or a doula, inserting legislation like the Momnibus Act that includes 12 bills that are addressing everything from incarcerated pregnant women to increasing the perinatal workforce. That is not physicians. So they are understanding that it's not just physicians' medical care and point of service that improves outcomes. It's all these other components that factor into reversing maternal mortality. The Babies Act, which is to develop pilot programs for birth centers around the United States, is growing in its co-sponsorship. And it is clearly riffing off of the Strong Start program that proved what you said, Lisa. How many times do we have to prove it? I don't know. But perhaps if the government would fund 6 pilot sites to replicate, again, building the evidence of safe birth in the community setting, that could make a difference. And the third is the Mama Act, which is, these have been around more than one cycle. People say it takes an average of 5 to 10 years to get a bill to pass. And it's probably true, but that doesn't mean you step back and don't keep arguing for what you know is right. The Mamas Act has various things built in it that talk about improving maternal health. One of my biggest soapbox issues is every state in our nation is not required to report maternal death. Guess where those states primarily sit? The Southern Poverty Block. So if hospitals are not required to report maternal death to a state agency, and every one of those maternal deaths are reviewed by a maternal mortality review committee, we don't know how many moms are dying in this country based on uniform variable definitions. And that is such a big part of the Mamas Act, including expanding Medicaid and many other issues. And what seems to happen is we add on things to bills, right? So on the Mamas Act, I just looked at it again this morning. You know what was just added to it? And I didn't realize till I read to the very end of the bill, a smoking tax. So now we're going to have the smoking lobbyists against the bill. And it has nothing to do with the body and the substance of the bill. So, it's difficult, but you cannot stop advocating. And we have got to build a consumer voice in this country. Their voice does matter, but I don't think they believe it.
Right. Right. But yeah, and I agree that they do. I mean, perhaps if we had a way, I guess that the way is for somebody to come up with a way for it to be done more easily, because everybody, you know how it's like if you ask somebody to call their insurance and do something, and they're like, I don't know how to deal with my insurance. Well, people
That's
don't
true.
know how to deal with politics, and how do I talk to the person who's representing me in our state or in our country. And I have issues with that too. And I do really like it when somebody gives me like a pre-made form that I can alter and then where to send
Yeah.
it. Those kind of things. It makes it a lot
Yeah.
easier. I guess if we can, we'll have to come up with something like that, I guess. And I do believe we should never give up. I mean, it just is like you and I and many, many midwives have given so much of our lives to this. And I mean, I don't regret a bit of it at all. And I have 4 daughters who all say that they don't regret that I have given so much of my life to it either. They know how important it is. But our clients, I mean, and you know how they love us. I mean, I just like deliver baby and then move on to the next thing. My husband says I spend my whole life putting out fires. So like whatever's important today, that's what I'm doing today. And then, so these things get put to the side. I hope that I'm really happy to hear though, how much is happening right now to our benefit.
Absolutely. And somebody made a comment, I think Jennifer, and I believe this to some degree, Jennifer, that once their birth is passed, their motivation is gone. If you compare it to other societal chronic issues, cancer, heart, lung, a variety of things where families face longitudinal crises. Addiction, it's gotten all the money for the last 5 years with the opioid epidemic. However, if we begin educating families on the front end, and it's part of the care package, look, this birth center wouldn't exist without X. Would you be willing to take a look at this electronic letter and send one to the hospital that coordinates care with us, or to the governor, thanking them that, in New Jersey, we can have a licensed birthing center. So there's constant affirmation coming in about it doesn't have to be all negative. Being positive is a part of feeling good about someone's contribution to the betterment of their state. I think sometimes if we see it as just a rant and people are reading these all day long, it doesn't move the mountain. It takes a personal relationship. Being able to know that you're going to be recognized at some time does have a little bit longer voice. If you're going to add money to that, maybe even more. But I still believe that power is in number. And if you had, 50% of your population that you delivered last year, Lisa, have a community-based experience, and you directed them towards sharing that positive experience with X, maybe it's the governor's office, what do you want them to say? And just deluge people with positive information. Maybe it's because they got to have a doula in addition to their birth partner. Maybe it's because you still did home visits versus being discharged at 8 hours from a hospital and only people called you on the phone or did a telehealth visit. What kind of support is that? It's minimal, it's support, but is it effective? We don't know the data yet. We don't know the data on the number of community or out of hospital births. We're confident it's higher. We don't know the outcomes data, and we won't for probably another year and a half.
Well, I think that one of the things that we were going to talk about a little bit today was independent practice, because midwives having their own practices compared to being employees of hospitals and physicians, it all kind of meshes in with your company too, because your company, Grow Midwives, has a substantial portion of helping midwives figure out how to open their own practice. What is the advantage to us for midwives to have private practices over being employees?
Well, it is a large growing component of our business. I didn't track folks for the first 2 years. We're now entering our third year of business, and I began to feel like, wow, I'm getting busy. This is something's going on. And we do work with hospital health systems, physician offices, and a couple of universities starting midwifery programs. But the individual midwife asks began to rise. And so in January of this year, nearly 50 midwives contacted us for help. And I would say about half of those were inquiries about starting their own business. And in February, we probably had over 40 contact us. And I think what we're beginning to see is a belief and a shift in the paradigm that you have to work for someone versus, no, I'm going to take control of my professional education. And I want to start my own business, and they're not real sure how to do it. And I can tell you, attorneys don't know how, dentists don't know how, veterinarians don't know how to start a business unless they have a friend or family member who can help them figure it out, and do it with a fair amount of accuracy related to cost. It's exciting because we really believe, as Kitty Ernst has probably promoted most of her lifetime, that midwives should be working for themselves and starting their own businesses. And I think as more states have autonomous independent practice, which we think is to your advantage if you're in one of those states, it's not impossible if you're not. The return on investment within 3 years, you're likely to start seeing turnaround to making a profit margin somewhere between year 3 and 5, whether that's starting a solo home birth practice, a practice with intention of only delivering in a hospital, or a practice as you have, Lisa, where you do all three. We're beginning to see those really increase, and it's really, really exciting to see that.
Yeah, it is. Well, uh, for me, I think that you're, I'm fascinated by your company because I just think it's filling a void that we've had forever, and things that I occasionally something would come up and I try to look at this gigantic organization in ACNM and find where I could get the kind of information that you have. And whether they had it or not, I don't know. I just couldn't figure out how to find it. And so this is a lot easier to find. But when I was starting this practice, I got so much help from Lonnie Morris. So a midwife, like probably the most famous New Jersey midwife, and she had her own birth center for years and continues even now to have her own practice. And I have to say, I mean, the midwives are not fighting against each other. Like we have a lot bigger enemy than ourselves. We're not competing with one another. We all should be helping one another start practices and get a foothold. The more people that have midwives, the more people will have midwives. Like, I don't think there's any concern about losing business. If we do 10% of the births in the country, there's 90% of births that we can get that we don't have to take from one another necessarily. And I mean, I'm forever grateful to Lonnie for so much information, so many phone calls, and so much, because it like you said, it's like, my husband is a business person, but he doesn't know midwifery and midwife business,
Yeah.
So,
well, we're excited to after, this period of sort of listening, and we've reviewed nearly 400 midwife contracts now. We have a pretty good idea on what's going on in midwifery contracts, salaries, if RVUs are snuck in there, how midwives can be taken advantage of. We also, at the same time, began to learn there are midwives that want to start their business, but they don't know how to do it. And short of going to AABC, how to start a birth center, there's not, from what I can tell, anything out there on how to start a midwife business. So we did a little bit of research, how to start a family medicine practice. We looked at how to start a derm practice. Believe it or not, there are these, consulting groups out there who focus on specialties. So we hired a team to work with us on creating a financial pro forma business tool, which should launch this month on our website. that is essentially what's required to get a business loan or venture partnership interest to sort of prove a budget and what it looks like on a pro forma 5 years out, with every element you can imagine that midwives would need and costing out down to, a microscope,
Mhm.
how to get your business started and the profit loss margin over those 5 years. So we're really excited to be able to launch that and take people's dream or fear to reality. And you've owned a business a long time, Lisa. It's not simple.
Right.
It takes a lot more than just the money to have a sustainable, scalable model. And we hope just to provide another tool to be able to help people do that.
That's great. It's so great. Um, I was going to tell you that one of the only times I ever talked to Kitty Ernst, I happened to call ABC for something. I mean, it's been a long time ago. Probably, I've been a midwife for 26 years. It's probably been like 18 years ago. It's a really long time ago. And I called to ask a question about something, and I got a lecture, a really long lecture about why I should not be working for a physician and why
Uh-huh.
I should absolutely be opening a birth center. And,
Uh-huh.
she made a big impact on me. I was
Yeah.
like, because, I
Good.
mean, everybody knows who she is. I mean, we
Yeah.
all, we all know who she is. And then for her to
Yeah.
like, talk to me so, same as I guess I feel like every time I talk to a group of people expecting babies, I feel like this is my opportunity. This is my moment to say everything I want to say to people. I'm going to say it all like as much as I can right now. That's what I felt like. She was like, I have this midwife on the phone and I'm going to tell her everything I want every midwife in this country to know right now. It was very cool. It was very cool.
Well, it's great to have those experiences, because I think sometimes it does take someone else having confidence when you're going to take a big jump.
Yeah.
Having confidence in the evidence to not, we don't convince people, but we give them the facts. Like, look, this is what we believe the reality is based on these assumptions you give us. But sometimes people just need to hear that it's not some harebrained idea, that it's a dream or a fantasy. And how different is it in a state like Kansas, and about 20 some others where you don't have full scope practice and autonomy? There are still states, New York, New Jersey, many where you cannot become a licensed independent provider in a hospital because they choose what the privilege and credential list is going to be, despite the fact that you might be independent autonomous practitioners. So, how do you navigate those challenges as well without feeling like you have to pay a physician to be your partner, to pick up the phone and say, hey, this patient has a derm problem, is it pups? Well, do they pick up the phone and expect to pay their cardiologist referral for a mom who has severe preeclampsia with cardiomyopathy? No, they work together, and that's what we're trying to promote in terms of real data. Because my partner, Leslie Rathbun, a past president of the American Association of Birth Centers, her own birth center, which she has now built a brand new one from the ground up and partnering with Medical University of South Carolina prior to moving. And she only moved because their collaborating hospital dropped obstetrics. They just quit doing OB in the community. The collaborating physician, which she did not pay, was generating nearly $100,000 a year in referrals, if not more. And he was devastated when he knew he was going to leave that partnership, friendship that they had. That, numbers help change attitudes. Numbers drive that conversation sometimes, when the decades of evidence don't.
Yeah. Well, and I mean, that's a lot of my goal. A lot of the reason why I do what I do is because I was, when I graduated from school, I was hired by two midwives who owned a birth center, and I had given birth at that birth center and then decided to become a midwife and went to school, and then they hired me, and that they mentored me. I came out of midwifery school with very little OB experience because I was an ICU nurse,
Mm-hmm.
so I had a lot to learn. So I had an entire year of being followed, mentored, and helped to become the midwife I am today. I really, in that year, surpassed most midwives I knew of my, my generation of midwives and what I knew about birth because of them, because they'd say,
Mhm.
when you see this, look for that. When this happens, this is what's going on. And so all the things that they had learned over so many years, they gave to me all in one fell swoop. Like in 1 year, I got all this wisdom. And Susan Stapleton,
Mhm.
she told me, she was my integration teacher. She told me, if the cord is tight around the neck on the perineum, she said, you got to really think about cutting that cord. She said, when you cut that cord, what if you can't get the rest of the baby out?
Mhm.
I have never cut the cord on the perineum one time in my career because I'm scared to death. I mean, I probably choke them pretty good getting him out, but the cord's still attached. So when I unwind it, the baby's got.
Yeah.
But those things, like I can tell you many things, many things that were said to me. And now, like we have an internship. We hire midwives just out of school, and
That's great.
haven't been practicing that long, and try to give them what I got, which I thought gave me a lot of my passion and my confidence in what I did, because they would tell, they were confident, they were
Yeah.
sure, they knew what they could to do. They knew they weren't afraid of birth, and
Yeah.
what midwives need. So when midwives graduate from school and they get jobs working for physicians or in hospitals in places that operate so much out of fear, and
Yeah.
midwives are supposed to not be afraid. Midwives are supposed to be confident, not
Right.
stupid, and not taking unnecessary chances and none of that stuff. But we are supposed to be, the holders of birth and all the good that it is, saying that. And so I think that that's why I'm doing this, is because you have to hire midwives. Midwives have to hire midwives.
Yeah.
Midwives have to work together, and so if we all work, just one little midwife sitting in a doctor's office, they'll never know, what I know is, and that many of our midwives, one of our midwives that we hired right out of school is now a professor at the University of Utah teaching midwives. And so she's there, a professor teaching, who did home birth, hospital birth, birth center birth, VBAC, water birth, like all those things. She's done all
Mhm.
things. And so she can go and teach now. I feel like that's like our legacy, Midwives in New Jersey
It is.
is happening, that she's out there teaching and giving confidence to people in a university setting. So anyway, that's a lot of, what you're doing is supporting midwives so that we can do our work. If all of us would invest in our profession like that, we would get a lot further. And I encourage all midwives to do whatever their part is. I mean, we all have some part, something that we really are passionate about or really feel about. And you lose time with your family, and you lose a lot of sleep. And, I have a lot of gut wrenching things like letters and emails that come that I'm like, oh, oh my God, now. But it does seem to work out. It's all worked out after all these years. It does work out. And so we have, we can do it. I mean, I do believe we can do it. I am an optimistic person. I just like to share everything I know. And I'm sad that so much of obstetrics doesn't want to know anything about what I know. It's sad.
Yeah. Well, I grew up, you heard me talk about being a scrub tech in nursing school. I was an RN in labor and delivery on evening shift for 1 year, and then I left to go start a birth center in Topeka, Kansas. It was the first state licensed birth center in the nation. I know MCA existed before us, but that's New York City. So we really were ahead of the game there. And for 14 years, I practiced at a birth center and did home birth, having been grounded as a labor and delivery nurse. And my kids, right, were born in a hospital, at home, and in a birth center. Those kinds of life experiences, everybody doesn't have those contexts, right? And see the normalcy, honestly, in all of the contexts that can exist and how that can be built and designed. But I'm going to take us back to what I believe. I do believe in the tipping point theory, which is when you hit about 18% of a societal issue, then you have a conversion. And we're getting really close to 18%. We're pushing 12. Hopefully we'll hit above that. And every year we make these decimal point increases in America in the number of births we attend. So my hope is before I die, I'll see us hit the tipping point. And I think our numbers are going to go faster because of COVID and maternal mortality. I hate to say they're leverage pieces, but they in fact are. And there are people recognizing it who never knew how to say the word midwife or doula before. So that's really positive. The other thing we're seeing in our business, just to protect our clients, I'm not going to name them, but we're working with 3 very large, influential health systems that either have 1 or 2 midwives that want to grow a midwife service that is midwife led and are highly contemplating an alongside unit, again, a European model, where one wing is just a midwife led wing and they do their own thing. And the high acuity patients are separated out, and the nurses who staff that ALU want to be there. There are about 4 or 5 that are accredited now by a new model that CABC rolled out. But we are so excited about working with these teams. And it's not just the midwives we're working with. We're working with the chief of the division. We're working with the finance department. We're working with administrative leaders. And I think it's possible. Is it a birth center birth? No. Is it a home birth? No. I've had all 3. But is it perhaps an option where more normal, healthy women who want to be in the hospital anyway would choose that might continue to propel the value of midwifery-led continuity of care?
I know I've talked to Morristown about that idea because, kind of going from that, what do they call it? Like a labor lounge kind of a thing.
Early labor lounge.
Yeah, isn't that a great idea? And I just figured that you could put everybody in the lounge and then move some people into the midwifery unit very easily, very seamless. Have a midwife run it, the lounge, and then people can move off. It would be, those are great ideas. And I'm really interested. I could probably talk to you forever and ever. But the people that are listening, I thought maybe we would let them talk a little bit because they came in on live. Do any of you have questions? Any of you have anything you'd like to say or talk to Ginger about today? I think if you raise your hand, Christina will turn your microphone on for you. No. I see. Hi, Barbara. Barbara Harper taught me an awful lot of things too, a whole lot of things about birth, that's for sure.
Lisa, it's Barbara. I never give up. And even though that gut wrenching happens, you know that you will get through it. And that's the thing, we have to be here to support each other. And throughout this, I just put in the chat, I want to see the labor lounges and the alongside units in the US before I die, please. And I'm 70, so get with it. I love you so much.
I know.
Barbara, thank you for everything you've done globally, but more importantly, being very self-centered domestically to integrate this option of water birth into America. I mean, long time coming. And I know the challenges are still out there, but it is a significant piece of change that's happened in our time.
It is. I used to say that I wanted my kids to put on my memorial stone or whatever they decide to do with me. At least you tried. And my kids have now said they refuse to put that on. They said, you persevered and succeeded.
Yeah. Yep.
So that's what we all have to do.
Now I have goosebumps under my shirt.
Yeah.
I think it's important to say that every every single person on this session, it doesn't matter to me if you have abbreviations behind your name or not, have the power to help change. You have the power to help change. And when you realize that, like in your soul, it will motivate you to ask Lisa or ask whoever, what can I do? It takes a bit of a jump to feel like we can fight Goliath, but I believe it. I mean, I believe the story, and I've seen it happen over my career. Just look at water birth. We have the living legend right here in front of us with an example of no one thought it would ever happen.
Right.
Things can change with persistence, but people have to help. As you said, Lisa, we need help.
I took rapid fire notes here, Ginger. The AMCHP that you started out with. Can you post the links for everybody? I posted the link to their website in the chat. But specifically the article that you were waving in front of us.
yeah. I'll do it right now so it'll get recorded in here.
Right. And Lisa, are you going to be putting this recording up? Because I know about 100,000 people that need to listen to Ginger and you.
Well, yeah, not me, but yeah, we are. It will be, and I actually, I literally last week worked every single day, every single minute last week, all the way up till this morning. And so I was going to ask the people, Chandra and Ryan, who are helping us run all this, our marketing people, how will you get this recording? I am not sure what the answer to that is. And I don't know if they're probably on here somewhere. If they could tell me, where will it be? Where will you find it? How can you get it? Chandra, do you know? Maybe she'll come on, but that was, I think, yes, absolutely. It's going to be recorded, and I'm sure we'll put it on our website somewhere, and so that you can find it. Lots of people are working right now, 11 o'clock in the morning, people are working, and so they didn't have time to listen, and I know they want to, and so we will, for sure.
So both the AmChip article and Barb and the other article, it's up a little bit higher in the chat board, not in the Q&A. Both are in the chat board, are there.
Excellent. I've just saved it to my articles already.
Yeah, hot off the press.
I now work at a birth center. I had to do things other than fly around the planet. And so I took over the childbirth education for a local birth center here.
Wow.
And what I found that was needed was midwifery supervision, because they come, like you said, Lisa, you come out of school. She was the owner was hiring new graduates, and they just don't get it. They have to be mentored. So a mentorship program, and I saw that you're doing that at the hospital, and that's incredible that you would mentor other people, other midwives, through that process of losing their fear and increasing their confidence.
Mm-hmm.
I think somebody wrote on here about, and I don't know that this is going to be the place to get this information, but maybe Ginger, talking about getting funding to open a birth center. Who wrote that? Somebody wrote that. Is there, Rita, did you say that? Ideas? Yeah. Did you want to?
Yes. I'm in an area right now where there are 2 CPMs practicing, and the CNM that practiced retired. So there's a whole group of Mennonite women and a whole group of women that want home birth. They can't get reimbursed because they're CPM. I lost my job a year ago after 27 years of practice. So they've contacted me. They've got a house, they've got an ultrasound machine, they've got a doctor that'll collaborate,
Mhm.
and they want to do it at a birth center, but they're kind of going at it, shall we say, ass backwards. So I've encouraged them to call Ginger, but I'm sure that this could be an incredibly viable practice. It just needs to be done well. But if we're going to do it for not the Mennonite people only, the hospitals keep saying they want to do it, but we need funding. I would say probably $100,000. We could get it off the ground. But that's our challenge right now. I'm finally getting radical enough about birth justice that I'm just not trying to be a good girl anymore.
One of the things, Rita, that we tell people who reach out to us to start a birth center, and this is people who do have no acquisition of a building yet, a lease or a purchase. They may not have even gone out to look at real estate prices yet, is to start a birth center. You've got to have some equity in it to get a bank loan, and you're looking at a $300,000 loan to open a 2 to 4 suite birth center. Now, the other thing we say is don't let money stop you. Just like I say to people who aren't sure if they want to go to college or not, don't let money stop you, because there are a variety of investors out there who are interested. And the problem is they're working with midwives who have good hearts, but no business sense. Now, that doesn't mean you have to have an MBA, but you have to know the reality of the business model. And that's where we're hoping our consulting and this financial tool will help.
They will be contacting you if I have anything to do with it.
Thanks, Rita. We're hopeful. We're hopeful that people are, go into it with the how to start a birth center mentality. That course is now online. You don't have to, be in person to do the AABC workshop, which we really basically say, we can't help you until you take that course and understand the basics of what that means. But what we're trying to do is take it to the next level of, okay, what are the financial implications of that to make it a reality? Hang in there, Rita. You can do it.
Hey, I just heard you guys say not to stop.
Don't stop.
Yep.
Don't stop. I'm 65, Barb. I'm not stopping.
Jennifer Santos, you wrote that about, and Ginger and I actually did talk about this, that it says in one part of our regs that we're independent practitioners, and then it goes on to say that you have to have a doctor. So we're not. That was, did you have anything to say about that?
Well, again, if you were talking to my husband, who's a lawyer, he would say nothing means anything until it's tested in case law. And so if that's not happened in your state, and you can have people stand up and go, look, this person signed a piece of paper that said they're going to collaborate with me, but we never talk. We never review cases. They take all my patients. I'm not paying them a dime, but here's this piece of paper that says we know each other. Cool. Who's going to go after you? Midwife by midwife by midwife in the state. Now you're listening to me. Probably no one. Unfortunately, that focuses on the CPM or those in traditional midwifery who have a much more difficult time, to some degree, outlining their core competencies and educational pathway. It depends on whether they came through an apprentice model or an accredited MEAC program. But again, I don't think anybody's interpreted that phrase. And I'm on the side of believing you interpret it your way until you're told not to. Right?
Yep, I agree. I know I'm independent. I'm very independent in most things I do. So I think that's why I'm a midwife, because I don't like to be told what to do anyway. So
yeah,
I think, which is true of most of our clients and us, that we challenge the norm constantly. And I encourage all midwives to never accept the status quo. It's like, even if you fight make the tiniest change, keep trying to make change. Don't ever just say it's okay the way it is, because it's not. And
right.
You just go backwards, Christina, who works with me the most, I always say, if we're not going forward, she's like, yeah, we're going backwards. But it's like, we always have to keep pushing hard. And I do see, just like you said, like we see like bit by bit, midwives are doing a little bit more births and a little bit more births. But it will happen if we keep trying.
It will happen. It will happen. And I do think we have to take ownership in our profession and those who support us with the doulas and support the doulas as well, to advance the profession by mainstreaming the conversation. Like maybe before your orientation to people who want to see about your birth center, or in your new OB visit when you talk to families, or in a doula's, first encounter with, this is what I do. Are you interested in me? A tiny little piece of the conversation is about the fragility of the model and why it's important that their voice is carried through their experience. So go on this journey with us in advocating for what you want. So A, the birth center can still exist, or B, you can still have a home birth next time, or your friends can, or your family members can, because that voice is just not being highlighted. And I think we're part of the problem. We haven't figured out how to convince the consumers to help us.
So Jill, do you have anything to say, Jill Wadnick?
I see you're there.
Hi, no, thank you for this conversation. I'm sorry I joined in late, and just to amplify how we need to move maternity care and make it everybody's business, get business and industry involved, get early learning involved, and think about a revolution in terms of sustainable funding for birth centers. So I wish I was on from the beginning. I'd love to learn more.
No, you can listen to it. We got it taped. So we'll let you. Anybody else have a question or anything you want to say? We have several of our clients on, and thank you guys for showing up. And some people, Casey Devine's midwife, that was just our student who was the CPM become CNM, and that was the easiest student I ever had because I didn't have to watch her do anything. I was just, I kept saying, just let her graduate. She already knows it. She already knows it. But it was so great because it was like having a whole nother midwife on staff for like 3 or 4 months. She's so great. And hello to you, Trish. It's always good to see you. And I really have enjoyed this a lot. And we do intend to do it again. I actually am hoping to have Ginger back on another topic and in the future. And our conference that we had to not have in 2020, and we are not going to have again in 2021 because we still don't know what's going to happen with people being next to each other. But Amy Romano was supposed to come and talk about intermittent auscultation and a lot of the data to support it. And it's that's a huge part of my practice. It's a huge part of delivering babies outside of hospitals using intermittent auscultation to make sure your baby's okay. And so I think that's likely to be maybe the next topic of a webinar. So stay tuned. And I think maybe in 2 or 3 months, we'll do it again. So if you're all good, I'll let you go and you all can go about your day, and I will post at some point how you can access this, or other people can access it and listen to it. And
Thanks so much, Lisa, for the invitation. It's been great to be with you today.
Very much. I'm so glad that I voted for you. I told you, right? I voted for you when you ran for president of the ACNM, and all because you wrote something nice about home birth on it. And I was like, that's my woman. So I was so proud of myself. I was like, I picked a winner. That was a really good one that year. So not that all the presidents aren't winners, but when you do something like not so traditional, it's nice to see that the leadership of your college has some interest in it. So it was very cool. Thank you so much. Have a great day. All of you have a great day, and we'll talk to you again soon. We'll see you again soon. I guess we just say goodbye.
Thank you.
All right. Bye now. I don't know how to turn it off though. Oh, yes, I do. All right. I'll turn it off now. Goodbye.